Are you taking a picture of that, Terry?
Nope. Video.
Okay. Oh, you're recording it? Yeah, the reason I say that is because I took a picture of this, but I'm now remembering what I added. So, yeah, very good, very good. I'm just gonna move on to Donna. So what are the signs and symptoms of toxicity?
Seizure, nausea, vomiting, GI upset, neurologic attack.
Very good, very good. So we got a lot of GI stuff, maybe some potential seizures, some confusion. So neuro and GI basically, right?
Yeah.
Very, very good. Then I'm gonna move along. So what puts a person at risk for lithium toxicity?
So then what, diuretics?
It's very specific. So I usually
Salt?
give to, yes, sodium,
Sodium?
high or low.
Both? Yeah. So if they have low sodium,
Bless you.
maybe that's what I put in my head.
Yes, hyponatremia, yes. Because lithium and the why is, lithium, where's the tissue? Am I looking straight at it? Oh, yeah. Geez. My God. Yeah. Oh, sorry. So, yeah. So it's like hydroxide and potassium. Those are the two you remember for the electrolyte imbalances, right? Good job. Yeah, it's a solid. It'll just take over. And it's not good. Not good. I would not want to have any seizures.
I'm sorry, you said hypo.
Yeah, yeah. Just like hypokalemia with digoxin, right? Okay, let's go to Josephine. We have got levocarby. So what is that? Levodopa-carbidopa.
That's medication for Parkinson's.
It is. That's good. Yeah, it's a replacement. And the carbidopa, what is carbidopa?
It helps us with
Yeah,
the brain barrier.
right, yeah, the BBB, to get in there to actually get to the brain and the neurotransmitters and stuff like that. Do you know, you guys, as a group, let me move back to Adriana. She's been raising her hand all day, she's ready. So, what is the side effect of levocarby? Ooh, I better hold on tight. I'm good, practical demonstration.
Fainting, sedation, dizziness.
Dizziness, yeah, a lot of obviously neuro things, but dizziness. So it's a safety risk. So we have to really watch for that. Yeah, they're kind of a safety risk anyway. People who take any sort of neuro drugs or has a neurologic disorder. Yeah. Excellent, excellent. Okay, Elizabeth. Okay, could you tell us what drug the enoxaparin is?
It's a blood thinner.
It is a blood thinner, anticoagulant, good. How do you administer it?
You can use subQ.
Yep.
But it says don't expel air bubble.
Yep, don't expel that air bubble. A lot of people, like with regular heparin, you have to get rid of the bubbles. But for the manufacturers, they designed it this way to leave a bubble, to insert that bubble, to inject that bubble. Because it helps for absorption, push it a little bit further down to the subQ layer, and so they don't bruise. Because that bubble will end up on top. So hopefully you don't get that bruising, because it's not attractive for patients. Patients hate the bleeding. Their family members will come and they'll go, look what they're doing to me. They have all this bruise. Have you seen that before? It's really funny.
Well, most of the time, patients bruise, like for the blood thinners, because they push it too fast.
Oh, yeah, that's true. So just in a normal, you don't want to be assertive with anything, besides adenosine, you have to get that slam. There's a couple good ideas, but yeah, very few things, you just, push it so quickly. Yeah. Oh, yeah. The other thing about the enoxaparin, and this is testable, that you want to make sure that the needle's all the way in that subQ tissue. Does that make sense? You don't wanna leave that needle like halfway hanging out, cause it'll come back and they won't get their full dose. So really get it in. So what does that tell you? You really have to find a good little fatty area, you know, the abdomen. Sometimes we'll do a tricep. But look at emaciated people. I want to ask y'all, how do you give emaciated people subcutaneous injections? Where do you find fat on them? Usually it's in their belly. And so what we have to do with that, you have to still, you have to pinch that layer up, go sideways. Because otherwise you're gonna find muscle, and we don't want muscle. Yeah. Yeah, there's some anatomical and mechanical issues that you learn over time, like how to do IVs well, how to do sub-Qs. Yeah. If I had you guys for an IV lab, oh my God, we would have so much fun. Because I like teaching the hard veins, like the hard sticks, because that's usually most of my career, that's all I saw. Because they would call me to start IVs, even on babies. Oh, I had a hard time with that because the babies would scream. And I'd be like, okay, just pay attention, get your line. But even after you secured the line, they would be almost blue. And then I say, breathe, like, you have to scare them. Okay. Remember when your kid did that?
Yeah.
Oh my God, I hated that. Oh my God, they're gonna die because they're turning blue. Okay, what do we have here? We have, hello, Noreen, are you ready? I'm finally getting her. I used to call you Irene. And the reason is you remind me of a former student, Irene. Almost exactly like her. Okay, oh, this is a good one. So you're working up on a medical unit where they have a lot of acute alcohol withdrawal. So what are the two benzos that are great for acute alcohol withdrawal?
Lorazepam and,
Yeah, you're right, and that's the most popular. Huh? Diazepam?
diazepam.
Yeah, those are very, very similar. I don't know, I think that they found lorazepam's a lot more effective. We don't give diazepam very much anymore. That used to be the mainstay, but now it's Ativan. And I believe that's it, very good. And how do you give it?
Pure IV push, or IV.
IV push for acute alcohol withdrawal. And then ultimately, they might end up on a drip. Oh, and if you're on a non-tele bed, you need to get that patient off the unit because they are seizure worthy. It will take a high serum lorazepam level to keep them from having that horrible grand mal time. So those are the worst seizures ever that I've ever seen. I mean, we've seen epileptic seizures, but acute alcohol withdrawals, oh my God, they're like great. They turn purple. They really do. And how do you oxygenate anybody like that? You really can't. You can put a mask on them or try to put a cannula, but still their breathing pattern is not great. I worry about an anoxic brain injury with those people. Oh my God, scary. Sometimes they'll get out of bed and they'll fall and then they'll seize. It's terrible. So we love nursing. It's the funnest thing ever. Okay, Sarah, we have a patient who is an, let's see where they have chronic atrial fibrillation. And on their medical records, or on their med rec and on their administration records, you have a drug to give to this AFib person. Could you name, I'm gonna challenge her, a couple drugs that you might give for chronic atrial fibrillation?
The one they would be taking at home is the
Yes, dabigatran, that's right. It works, obviously all of these are anticoagulants, working off the coag chain. And they might take other things like digoxin to lower that atrial rate and therefore lower the ventricular rate. Very good. So dabigatran, very popular. And what is really the purpose of us wanting to anticoagulate them with a chronic anemia? So they don't have a stroke, yep, that stasis of blood, very dangerous. All right. What is this one? Oh, very good, Michaela. So you are working also on a medical unit. Your patient was admitted with a DVT and a really bad one, very, very dangerous, real swollen, red hot leg. And so they put him on a heparin drip, right? So now they have a GI bleed. And so you now what will they order? If they're bleeding like that, or starting to throw up, what are they gonna order? Right away, stat, med-emerg. Blood draw wise.
Would be INR?
That would be for what drug? INR is for warfarin. So this is heparin, right? Heparin drip. PTT, that's right. PTT or APTT, heparin XA, unfractionated heparin. But yeah, so you get a coac, whatever your hospital's coac is for heparin. And then the doctor will then say, oh crap, we're really hyper anticoagulated. So what are you gonna be giving to reverse them?
Protamine.
Protamine, yeah, protamine sulfate, very good. How do you give it? Yes, most of your antidotes like that or ACLS are given on a week push. It's gotta be fast, direct and to the point. And then of course, they're gonna be giving, in that case, if they're throwing up blood, they're probably gonna get H&H, see what their H&H is. You're gonna probably get a type and screen for blood transfusion. So you're gonna be getting a lot of orders right then and there. Maybe even a bolus, depending on their blood pressure. If they're hemorrhaging, which they are, you're probably gonna have to bolus in some saline, probably gonna have to give some blood, give that protamine sulfate, so they don't bleed out completely. Once that GI bleed starts, let me tell you, it's a very vascular organ, and they can bleed out pretty darn quickly. Okay, good.
Patients bleeding now, like burning up the blood, would they at that point give the Sanderson?
Yeah, if they were in the ED, probably they would do that. Yeah, they probably would have said, especially for the esophageal varices, because the sandostatin, it's a little bit different. What the sandostatin does is it vasoconstricts. So you have different, meds for bleeding for different indications. And what sandostatin do will constrict those varices very nicely. Does it do a little bit of vasoconstriction? I Googled it, I had to research it nominally, and the risks of that outweigh the benefits. Or the benefits outweigh the risk of having a systemic vasoconstriction. Does that make sense to everybody? So this is for those acute esophageal varices bleeds, octreotide, definitely, piggyback, yeah, because of drip. But in this case, we can, since they're on a heparin drip, we know that we can reverse that coagulation, yeah, and then treat accordingly. Oh, hello. Not that, that's Alyssa. Jen, Alicia.
No.
Don't you guys have the same name?
Ashley.
Ashley, okay.
No.
And yours again? Jenna, see, oh gosh, yeah, like I told you, got really bad. Okay, wound infection. What do you have to do? So you notice that your wound, not yours, your patient's wound is stinky. And so you go, oh no, let me look for my white count, right? What are the things you look for in that wound?
You have to get a culture of it, right, and then before you can get into that, is the
Yes, that's the answer.
Okay.
She knew exactly what to answer, that was very good. But really diagnose it, that there's an infection as evident by the redness, maybe some drainage. You're smelling something under that dressing, you're like, oh, that's big. To really take a look-see at it, and certainly if you have some purulent exudate, gotta call the doc, call the infectious doc, and with that, vital signs, of course, make sure you look at your labs for the white count, especially if they're big fall. They're probably not at that point, maybe it's closer to a minute, a couple days out, they might be diabetic. Yeah, diabetics can grow stuff really quickly, so it's feasible they could have an infection in there. Anyway, yeah, so vital signs, your white counts, all your labs really, and your vital signs, and your findings. Red, hot, maybe even a split in a little bit of, it's not a proximity starting to split, eviscerate a little bit. And then, yeah, all your numeric stuff, and you're right. Then you get a Q-tip, right, you go in there and you dig a little bit, get a good sample. In other words, poke it in there, it may hurt, it's good, cause it's inflamed already, but just say, I need to really get a good sample, be gentle with that, you know? And then send it to the lab before you give those antibiotics, good job, very good. You guys are getting the basic concepts, it's gonna be on the board, that's a board question right there. Okay, Ashley, we have, what do we have there? Oh yeah, cephalosporin. So, what do you know about cephalosporins?
They're antibiotic, broad spectrum.
Very good. Is that what you're gonna say, the psyllium and the cephalosporin?
Yeah, those are two.
Yeah. So if you have an allergy to one, you're most likely, or, you know, potential of having. So it's cross allergenicity, cross hypersensitivity, absolutely. And what is a big side effect of the cephalosporins? Would you like for me to give you a practical demonstration?
Yes,
Or remember?
No. Diarrhea.
Yeah, loosey gooseys. And then when you have diarrhea, when you have a kid who has diarrhea, or you have a patient, what are your concerns with diarrhea? Yeah, loosey gooseys. So what are we gonna do? Are we gonna give them Pedialyte? It depends on their blood pressure. It would be nice if we could give Pedialyte. Probably on the kids, but we give them, you know, we look at our labs, we see if they've lost some potassium. Probably give a 0.9% with some KCl in there. Yeah, it's mostly about sodium potassium loss. And of course the volume for hypotension. Yeah, we gotta treat them. Oh, there are meds that you can give to stop the diarrhea? Ooh, that's a good question. Did you guys learn about that last semester? Because we haven't talked about antidiarrheals so much. Besides, Pepto-Bismol is sort of I took that on the test. Huh? Oh, yes, loperamide. Yeah. And then we also have, what's the other one, Lamodal, which is atropine and diphenoxylate. It's an opioid, believe it or not, diphenoxylate is an opioid, and then you have the atropine. That makes sense, doesn't it? Because atropine slows motility, and the diphenoxylate, what does opioids do to your blood? Slows the motility, right? So that's a controlled substance because of the opioid narcotic. So yeah, you gotta watch it very holistically. When you have a patient that has watery stools or loosey-goosey stools, you gotta look at everything. Oh my God, you know, how's their blood pressure? How's their trigger? And then report those findings and then treat it accordingly. All right. Before I forget, I've got to also have to remember your med list that I get, your study list. And let's go to Terry, And I know one that's on there is going to be your, plasma. So what do you give plasma for? Speaking of low blood pressure.
Anybody who's losing fluids?
Yeah, that's right. So somebody's lost blood and we need to do, fluid resuscitation, or they have maldistribution of fluid, like in a burn. Oh my God, it's like this. Like if I had 50% BSA, body surface area burn, and all of that fluid inflammation is gonna shift, where does that fluid come from? The vasculature. And so plasma is perfect for that. Because Terry, what does plasma do that's kind of special, that saves that person's life?
It volume expander?
What did you say?
Volume expander?
Yes, that's exactly right. We have some, body language back there.
Sorry, Mom.
No, it's it, yeah. It expands volume, or that could also mean it sucks the fluid into the vessel. And what's great about plasma or any of those volume expanders, the molecules, the protein molecules are so big, they stay intravascularly, which that water that follows is gonna stay there, because the protein doesn't float back into the interstitial space or into it. Isn't that great? Plasma is so life-saving for that reason. And so as a result of being a volume expander, your blood pressure is gonna go up. Lots of lives are saved with the plasma. Very, very good. Okay, let's go to the back. Oh, ED. I bring up ED because a lot of these situations happen in the ED. It can happen anywhere, but. So your patient comes in and, oh my gosh, they have a hypertensive crisis. So you obtain your medication reconciliation sheet, which has all their meds. Why would that person, what medication do you suspect with a hypertensive crisis? Oh, she's got it. Oh, that was fast. Wasn't that fast? But I got this. Yes, very good. So you work the evening shift, right, or the night shift. They came from a Christmas party. So what do you think that they consume to cause them to have that hypertensive crisis? Tyramine. And what foods contain tyramine?
Wine, cheese.
Yeah. And the guy was drunk too. He was drinking a bunch of wine. He had that charcuterie tray, deliciousness, right? But he says, oh, I forgot. Or nobody told him. Maybe it was his first run of taking, MAOIs. And no nurse or psych doc, taught them about the MAOI. So is it part of our responsibility? Of course it is. I mean, that's a huge education piece. Yeah, so anything aged, or fermented. Mm-hmm.
Damn.
Okay. What we have next is, we've already talked about the concept of the cross allergenicity, so let's move on. Oh, yes. We've actually already done this one, but let's do it again. Again, ED, these usually happen in the ED. Agitation, confusion, hypertension. And you look at their medication list. What's to blame in this case?
Possibly serotonin.
Yeah, yes. Excellent. So that's going to be, what group of drugs would cause that?
The SSRIs.
Yes. Ooh, you guys are getting this. Good base for your CMS. Oh yeah. Everybody was taking Prozac back in the day. It was like 90s. That's when I think that's when they made a lot of their money. And then somebody wrote a book, Prozac Nation, yeah, talking about this nature. Lots of depression, why? Oh my gosh, so much fun. No, you know why? It's genetic sometimes. And people go through crap. It is actually a physical thing. You're lucky if you don't have those. All right, are we ready? Sorry, please leave the other. Oh, this is very good. Same situation, except you're working in the critical care unit. Patient's able to take all of their meds via a feeding tube. And you've given all of their antihypertensive, their psych meds, and you've given everything. And it's a new patient there. They just sort of came to you. The findings you're starting to see is hyperpyrexia, diaphoresis, and changes in the blood pressure. And you're starting to get worried. What do you think is to blame? Do you think it's medication based?
No, I wanna say is it NMS? No.
Man, you went this way, said, oh darn, and then NMS, that's it. Yay, good job. I thought you were gonna go in a different, didn't you think she was gonna go in a different, because I said, do you think it's meds? Yeah.
Well, it's meds, but like, it's
Yeah,
malignant syndrome, so I was like, no.
That's great. And what kind of meds, if you go to Ray Lonnie, what kind of meds can cause those, NMS?
Is it muscle relaxers?
Drugs like this, even though this was not.
So it's antipsychotic.
Yeah, a lot of them, like, which drug do we have on here, is it Betelzine?
Dantrolene.
Or,
Is it Flexeril?
no, those are, what is our, besides this one, didn't I put another antipsychotic? We'll get to it. I'll figure it out as we go along. But generally, antipsychotic, so can it cause all kinds of different, not only the NMS, but can it also cause, what's the other thing that antipsychotic drugs can cause?
That's
Is what I'm trying to spit out. And let's go to the back there. Besides NMS, what's another thing? I could do a practical demonstration.
Oh, tardive, dyskinesia.
Yes.
pills.
Yes, all these, extrapyramidal movements is what we do is we put those into a bucket, don't we? And you're right, tardive dyskinesia, she was giving the nice practical, she was doing the mouth thing. Yeah, cause tardive is mostly mouth, not usually large muscle, it could be, but it's usually the face. Yeah, okay, very, very good.
Professor
yeah.
Dakin, so you said antipsychotic causes NMS?
Oh, yeah.
Okay.
Oh, yes. And so there's two things with antipsychotic, NMS and also extrapyramidal movements. Those are the two things that are board worthy. Yeah, and CNS.
Could you, say that when you answered the questions, what were the manifestations that you gave her?
Oh, what were they?
Hyperpyrexia, diaphoresis.
Okay.
Yeah, and what's hyperpyrexia?
Hyperpyrexia.
Ooh, you guys are so smart. That's really good, you guys are getting good. Because oftentimes, PY actually in science can mean two things. Either like a pyromania, heat, that's a good way to remember it, and pus. So you're gonna see that actually in two different things. Pus or pyro.
I think clozapine is the other antipsychotic.
Yeah, added that. It seems like there's another one that I added.
Risperidone or olanzapine?
Wait, I think you're right. I'll find out as we go along. Yeah, I think it's risperidone. Yeah, I'll let you know. Okay, good. You answered, didn't you? Yes. We have now midazolam. Oh, I'm gonna get some on Friday. Oh, I can't wait. Oh my God, it's gonna be such a fun day.
Good.
Midazolam. What is it?
It's percent,
Yeah, it is Versed.
and has possession of GABA.
Yes,
Um,
yes. I'm sorry.
Some complications are amnesia, respiratory distress, depression, nausea, vomiting, diarrhea.
Yeah, I would say that the other ones are, the amnesia is a side effect. And then the other ones are they under side effects or adverse effects? I know ATI usually blurs the lines there. Anyway, regardless, those are all potential side effects, but definitely the consistent one is going to be that amnesia. Is that a bad thing? It's not, because they don't even remember they had their surgery. It's like, great. Yes, bless you. What was the other thing I was gonna say? Oh, and then the action. Let me just, and she's right, it stimulates GABA. And what exactly is GABA? It's an inhibitory neurotransmitter, so it stimulates it, therefore it inhibits the CNS, right? It's great, so it's a CNS depressant. Yeah, it's our major procedural drug, isn't it wonderful? Yeah, last Friday, guess what I got? I got some nitrous oxide. Oh, it was fun. I started laughing too. They had some music going, they were talking about the music, and I don't know, the tech, she said something funny, and I laughed. And then the doc, she says, let's lighten her up just a little bit. She's getting high. She's literally getting high. Okay. So back to the front, I have 2 minutes and then we'll take our first break. Oh, you're gonna love this. So you're working up on an orthopedic unit and your patient has, they're being treated for osteomyelitis. Osteomyelitis is really hard to treat. Once it gets in the bone, they're gonna have that infection probably the rest of their lives. You have to take antibiotics. Once they get that MRSA, usually it's MRSA or something like that. So, you're actually giving an aminoglycoside antibiotic. So, what are the aminoglycosides in terms of their name? Yeah, myosin, Yeah, very, very good. So what do you know about the myosin antibiotics?
They kill the bacteria that, or by blocking ribosomes from
What?
mRNA.
Protein synthesis inhibitor, wow, we didn't even talk about that. You got that from your own studies. And in terms of adverse effects, what are you gonna be watching for?
Ototoxicity and nephrotoxicity.
Yeah, very good. You were doing really good with that. And how do you know if they're getting nephrotoxicity?
Is it tinnitus? Is that,
Nephro?
yeah, or is that,
No.
that's the,
Yeah, so how do you know, not necessarily pain, but how do you know that they're nephrotoxic with any drug? How do you know the kidneys are not working? It's easy.
like my drinking. I feel like I know it and I can't think of it.
Well, if your kidneys are going into
Yeah.
failure, yeah, that's the first thing, right? You can't pee, and then of course we probably run B1 creatinine will be elevated. And you're right, and with the odo is gonna be the tinnitus, yeah. And sometimes they complain of like, sounds muffled, like I can't hear very well, like I'm having ringing. It's great time. It can cause permanent damage. Yes, okay, good job. Okay, let's take a break. Y'all are doing